Hello everyone, welcome to yet another session on our teaching, and in this session we'll be discussing completely about liberation and weaning from mechanical ventilation. So my presentation will deal with these bullet points. First and foremost, what is weaning? Definition of weaning. We will classify the patients, how to enhance weaning, what are the readiness to breathe without assistance, the ABC of weaning failure, and current evidences to perform safe extubation. So, what is weaning? As we can see in this picture, it is the landing of the flight on the runway. So, being a pilot, you have taken your plane off. Now you have to safely land this plane on the runway. So, whatever precautions which are needed for weaning are to be essentially known by an intensivist, and what are the essential criteria and prerequisites which you should take care of while weaning your patient from ventilator. So the milestones of the weaning are, first and foremost, for any disease cause, you are performing an intubation, going on with sedation. Start weaning by reducing the ventilatory supports, patient triggering the ventilator. You want to switch from the control mode to an assisted mode, give a spontaneous breathing trial, and then extubate your patient. These are the milestones of weaning. Now, by definition, weaning is the process of withdrawing mechanical ventilatory supports and transferring the work of the breathing from the ventilator to the patient. Weaning success defined as extubation and absence of ventilatory supports 48 hours following extubation. Mind it, this is 48 hours. Once you have extubated, absence of ventilatory supports 48 hours following extubation. Weaning in progress. What is weaning in progress? It is requirement of NIV after extubation. Simple weaning is patient who proceed from initiation of weaning to successful extubation on the first attempt is simple weaning. These patients are those who can easily be weaned from ventilator. Difficult weaning. Patients who fail initial weaning and requires up to 7 days from the first spontaneous breathing trial to achieve successful weaning. Prolonged weaning. Now, what is prolonged weaning? Prolonged weaning is requiring more than 7 days from the first spontaneous breathing trial to achieve successful weaning. Now, once if you are able to wean, it's good. Your work is applauded. But if there is a weaning failure, what is weaning failure? You have failed the spontaneous breathing trial or re-intubation or resumption of ventilatory supports 48 hours following extubation. Or the newer definition also includes death within 48 hours following extubation. So, limitations: patients not successfully weaned, tracheostomized patients, and post extubation NIV for more than 48 hours. The usual process of weaning from ventilator, a very smooth landing. It's a simple weaning. The two-step strategies are, first you have to assess that whether your patient is ready, there is a readiness criteria which is met by the patient or not. And the second is spontaneous weaning trial. So readiness. Now readiness testing can be done either by an objective clinical criteria or physiological test known as weaning predictors. The readiness criteria, the underlying reason for mechanical ventilation, the reason why you intubated this patient. If that very reason has been met, taken care of, and your patient is improving, This is the first and the foremost readiness criteria, the clinical criteria. Patient is hemodynamically stable or on minimal to no vasopressors and is off sedation. Oxygenation, the PF ratios are more than 150, the PEEP is less than 5 to 8 centimeters, and FiO2 less than 0.4. The patient is able to initiate spontaneous inspiratory efforts. Patient is afebrile, temperature less than 38 degrees. Stable metabolic status, that is pH more than equal to 7.25, adequate hemoglobin at least more than 8 grams per deciliter, adequate mentation, arousable, GCS more than 8, and oxidation. Now, readiness criteria, you have to optimize the fluid balance before weaning. A positive fluid balance, especially those ICUs which have cumulative positive fluid balances, adversely affect their alveolar ventilations, oxygenations, weaning progress, and extubation outcomes. Then comes, after clinical, the physiological tests. Numerous physiological weaning parameters are there. None of these parameters appear to be superior to objective clinical criteria in predicting a patient's readiness to weaning. Physiological tests may be that you have measured the ventilation, that is the minute ventilation, the strength by maximum inspiratory pressure, endurance by MVV more than 2 times the minute ventilation, neuromuscular, the absence of scalene or abdominal muscle activity, and FiO2 less than 0.5. So you may have static compliances measurement, occlusion pressures, prop index, core index, weaning index, integrated weaning index. None have been confirmed to have a high level of accuracy as that was initially reported. Another weaning predictor, we are living in the era of ultrasound, so diaphragmatic thickening and diaphragmatic expansion. Rapid shallow breathing index, RSBI, awake, oxygenated, stable. The rapid shallow breathing index is assessed by putting the patient on TPs or CPAP for 2 minutes, minded for 2 minutes, and frequency by tidal volume in liters should be less than 100 in which is a successful predictor of weaning. It has a sensitivity of 97% and specificity of 65%. But the newer concept, again, one step ahead, we measure the serial RSBIs and calculate the RSBI rate. To prepare for weaning, always communicate with the patient, explain the procedure, calm them down, record baseline parameters, and keep flow sheets at the patient's bedside. Keep a calm, peaceful environment and have the nurse or physician remain at the bedside to offer encouragement and support. So, weaning, no sedation, it's your maximum cooperation and efforts. Whenever possible, position the patient upright in the bed, thoroughly suction the endotracheal tube and ensure patency. Methods of weaning, traditional methods are spontaneous breathing trial, pressure support ventilation, or SIMV. The methods of weaning are, newer methods are computer driven, pressure support ventilation weaning, early extubation with immediate use of post extubation non invasive ventilation. Spontaneous breathing trial. A spontaneous breathing trial to a patient breathing through endotracheal tube either without any ventilatory support through a TPs or with a minimal ventilatory support, a low level of pressure support, or an ATC or a CPAP for about 30 to 120 minutes. These are the two methods of spontaneous, either give a pressure support or give a TPs trial. T-tube trial, low levels of pressure support 7 to 8 centimeters, 10 centimeters in pediatrics, just to overcome the resistance of endotracheal tube. CPAP, automated tube compensation adjust for assumed resistance of endotracheal tubes. A spontaneous breathing trial, the type of SBT, that is TPs, low level of pressure support or CPAP is dictated by local availability and clinician preference. Duration of a weaning trial, a prolonged spontaneous breathing trial does not appear to be superior to a shorter spontaneous breathing trial, that is 30 minutes. 30 or 120 minutes are same. Duration of weaning, prolonged SBT does not appear to be superior. Minded persons who are giving a spontaneous breathing trial for 1 day, 2 day, they are actually harming the patient. If your patient is meeting the readiness criteria, a simple 30 minutes of spontaneous breathing trial, you will be able to assess whether your patient is tolerating this SBT or not. The results of 30 or 120 minutes are same. Monitor closely during the spontaneous breathing trial, whether your patient is comfortable, vitals are same, respiratory parameters. SBT should be terminated if it fails. So the failure of SBT assessment are patient becomes agitated, anxious, mental status is depressed, diaphoresis is there, cyanosis is there, increasing inspiratory efforts or increased expiratory muscles activity, facial signs of distress, and dyspnea. Failure of SBT, objective measurements, where PO2s will fall less than 50 to 60, PCO2 more than 50, pH less than 7.32, rapid shallow breathing index more than 105, respiratory rate goes above 30, heart rate goes above 140, systolic blood pressure goes more than 180 or more than 20% increase, or diastolic pressures less than 90, or cardiac arrhythmia start. These are all the signs of spontaneous breathing trial failure. The ACCP guidelines say that if SBT fails, find out the cause of failed SBT. Once the reversible cause for failure are corrected, and if the patient still meets the criteria, perform a spontaneous breathing trial after your failed attempt after 24 hours of it. So ventilation after SBT, a stable, non-fatiguing, comfortable mode of ventilatory support. It is not so that if you failed a TP's trial, just put the patient on CPAP and leave apart. You have to make it in a stable, comfortable form of the ventilatory support for next 24 hours. So this is what is needed. Failure of SBT, other methods, trial of SBT after 24 hours, preferably for 120 minutes, weaning by progressive decrease in the levels of pressures. Go very slow, decrease the pressure supports by 2 to 4 centimeters. IMV alone is not used for weaning. Extubation criteria that define success of SBT does not necessarily reflect the likelihood of successful extubation. So you may be able to wean the patient, but still extubation is the task which is left. About 10% of the patient who are successfully managed on SBT will fail to maintain adequate gas exchange or develop signs of distress following extubation. So this is again to be kept in mind. Extubation SBT has been done, usually assessed to assess the load and the capacity, but does not predict that it will lead to successful extubation. SBT you are performing just to assess whether your patient is ready to be weaned from ventilator or not. Again, there are certain other factors which will be contributing to a successful extubation. That includes upper airway potency, bulbar functions, what is the amount of sputum load, and the cough effectiveness. These will be deciding your extubation criteria. Successful extubation defined as absence of need for ventilator for next 48 hours. Patient receiving post-extubation NIV are again labeled as weaning in progress. Prerequisites, cough reflex should be adequate, spontaneous or while suctioning, patient should be able to protect the airway, secretion should not be copious. Cuff leak or less than 110 ml. This is a cuff leak test in which 110 ml, if we deflate the cuff and the leak is less than 110 ml, on the assist control ventilation that helps to identify this patient may likely to develop post-extubation stridor or obstruction of the airways. Prerequisite, no radiological or surgical procedure is being planned in the near future. Extubation should not be done at the end of the day. To extubate the patient, the readiness criteria should be met. Cough power has to be assessed. The amount of cough has to be, amount of secretions have to be again assessed before extubating. Peri-extubation care. Aggressive secretion clearance, respiratory clear, fluid balance. Consider nasal airways, airway pre-extubations. Inspect airway prior to extubation. Humidify intermittent or nocturnal BiPAP if required, nasal bronchial oxygen by mask. Monitor for extubation failure. If there is any sign of respiratory rate going more than 25 minutes, heart rate more than 150, or clinical signs of respiratory muscle fatigue or increased work of breathing, monitor for extubation. Saturation going less than 90 or hypercapnia PCO2 going more than 45, again extubation failure. So weaning failure, stormy wind, you may land up into a weaning failure. So if you land up in such a situation, what you need to do is assess your weaning failure. Etiology should always be sought. Common causes of source of respiratory failure should not be fully corrected. What is the pathophysiology of weaning failure? Definitely the load on the lungs are exceeding the capacity of the lung. That is why weaning failure is happening. Now the load, there can be an elastic load, resistive load, or ventilator demand. Elastic loads, as we say, P, pulmonary edema, pleural effusion, abdominal distension, atelectasis, this is elastic load. Resistive loads, lot of secretions, bronchoconstrictions, endotracheal tube is skinned, or by patient is biting it. That may lead to resistive load. Ventilatory demands, Dead space ventilation, metabolic acidosis, anxiety, pain. This is regarding the excessive load. When excessive capacity is compromised or low capacity is there. In case of a neuromuscular disease, oversedated patient, CNS problems, malnutrition, sepsis, hypothyroidism, this will be the decreased capacity. Ascertain the cause of weaning difficulty, like unresolved pneumonia, unresolved pulmonary edema, fluid overload. Unresolved pulmonary edema, excessive fluid administration may delay weaning. Re-establish the baseline fluid balance. Consider albumin with furosemide. Treat pulmonary edema aggressively. Avoid fluid overload in renal failure and cardiac failure. Poor cardiac performance. Maintain adequate cardiac output and tissue perfusion. Treat arrhythmias. Get an NT-proBNP done to look for the excessive fluid or fluid overloads. Ascertain the cause of weaning difficulties, like in pulmonary embolism. Sprinting effect of obesity. If the patient is obese, abdominal distension is there, or ascites or effusion is there, again it can be a cause of weaning. Drain out the significant pleural effusion, ascites, treat intra-abdominal hypertensions. Again, nutritional causes may be there: hypokalemia, hypomagnesemia, hypocalcemia, hypophosphatemia, hypothyroidism, anemia. Nutritional deficiencies and metabolic deficiencies have to be corrected. Anemia has to be corrected. Target more than 8, at least 7 to 8. Treat all reversible causes like hypothyroidism, steroid deficiencies, or excess. Respiratory muscle fatigues have to be taken care of, like corticosteroids. Myopathy leading to myopathy, hyperglycemia, hypothyroidism, chronic renal failures, impaired diaphragmatic functions because of sepsis. Treat reversible causes, discontinue use of steroids, aminoglycosides. Colistin again will interfere into the weaning. Statins will interfere into the weaning. Respiratory muscle fatigue and weakness, poor cardiac performance, neuromuscular dysfunctions, and drugs. Persistently increase work of breathing, ineffective triggering. Reverse bronchospasm as much as possible and reduce dynamic hyperinflation. The weaning, WIN 22 of 2017, weaning according to new definition introduced the concept of separation attempt. So if we label it as a separation attempt, and SBT or extubation in the intubated patient, and by 24 hours of spontaneous ventilation without any mechanical support through tracheostomy and tracheostomized patients. We give us WIN-SAFE, worldwide assessment of separation of patients from ventilatory assistance using a modified version, failed wean. A group of patients who have at least one separation attempt but never successfully weaned. WIN-SAFE tells failed wean, at least one separation attempt but never successfully weaned. Prolonged wean, successfully weaned more than 1 week after the first separation attempt. No separation, never had a separation attempt. Short wean, successfully weaned within the first day after first attempt. Intermediate wean, within 1 day to 1 week of the separation attempt. This is intermediate wean. So this is regarding the WIN-SAFE trial. Weaning success because some devices can be used after extubation to prevent reintubation, like an IVHFNC, and these techniques can delay reintubation of patients who have been otherwise intubated within 48 hours. To limit this uncertainty, most studies choose to define weaning success as breathing without NIV for 7 days, or being discharged without NIV if this happened before 7th day. How to fasten weaning? Again, demonstrated previous use of neuromuscular agents and the level of sedation at the moment of meeting eligibility or first separation was achieved delayed weaning and weaning fear. Avoid ventilator-induced diaphragmatic dysfunctions, certain respiratory efforts, control dysynchronies, and monitor respiratory. Spontaneous breathing trials. Two main modalities, TPs, pressure support with no PEEP or low pressure support. SBT failure criteria, you should be remembering that. And the recent study again has compared the 2 hours of TPs trial, a more challenging test, to a 30-minute of pressure support trial, less challenging test, found benefit with a higher success rate of successful extubation and with a less demanding test and less agony to your patient. So give a 30-minute of pressure support weaning trial and try to successfully extubate your patient. Again, remember, whenever you are approaching a weaning failure, assess ABCD: airway, lung dysfunction, brain dysfunction, cardiac dysfunctions, diaphragmatic dysfunctions, and endocrine dysfunction. So, respiratory mechanics taken care of or not. SBT failure in COPDs, as you already know, bronchial calibers, reduced bronchial calibers, intrinsic PEEP, dynamic hyperinflations interfere. Brain dysfunction, delirium, depression, anxiety, sleep deprivation. Midazolam in itself is a risk factor for development of delirium. So always use a CAM-ICU trial. Use dexmedetomidine as compared to midazolam. Cardiac functions during weaning failure like CAD, CHF, COPD again will interfere. So get help from NT-proBNPs. Assess extravascular lung waters. Use ultrasounds to delineate B lines. Do the B line charting daily. Change in the plasma protein concentration of more than 6%. Preload reduction by diuretics, BNP guided fluid therapy, and afterload reduction by nitrates or ACE inhibitors. Best is to use an IV supports when we are weaning the cardiac patients. Now, diaphragmatic and respiratory muscle fatigues. Always never drive. Most weaning failure respiratory drive is increased. Critical illness, polyneuropathy, myopathy can be a cause of decreased drive. Weakness, maximum inspiratory pressure in younger than 65 years old are less than 75 centimeters in men and minus 50 centimeters in women. Values which are more negative virtually exclude significant inspiratory muscle weakness. Less negative do prove muscle weakness as one of the criteria. So, treatment strategies, mechanical ventilation is a double-edged sword. Respiratory muscle training and diaphragmatic dysfunctions. Antioxidants modulate respiratory functions in healthy subjects. Effect of glycemic control on clinically relevant outcomes of parameters are definitely seen. Now, role of corticosteroids. Importance of corticosteroid in weaning failure. Either their relative deficiency or supplemental need further analysis. Exposure to exogenous corticosteroid during the ICU stay might cause muscle weakness, possibly contribute to prolonged duration of mechanical ventilation. And again, corticosteroids might interfere into the glycemic control. Metabolic disturbances, take care of your phosphates, magnesium, and potassium. These all causes muscle weakness. Rule out hypothyroidism, hypoadrenalism, which may also contribute to difficult weaning. Risk of reintubation, 10 to 40%. Actually, post-extubation respiratory failure is most frequent complications after extubation. Patient characteristics, more than 65 years, obese, underlying cardiac disease, underlying respiratory disease. These are all the characteristics for weaning failure. Acute illness, related to acute illness, reason for intubation, maybe polytic cumulative balance, weak power or cough, abundant secretions, ICU acquired weakness, prolonged mechanical ventilation, and a high respiratory severity scores. So, how to prevent reintubation? Always compare. Comparison of strategies applied directly after extubation. They say use either NIVs or high flows to prevent risk of reintubation. Points to remember. Prerequisite for weaning is reversal of the indication. Always remember, you may be hammered 1,000 times that you extubate my patient early, extubate it and remove my ventilator. Always see the reason why you intubated this patient. If that reason has been met, the disease is improving, then the weaning can be attempted. Adequate gas exchange with minimal oxygen and ventilators. Most successful predictor of weaning is RSBI. RSBI less than 100 is the successful predictor of weaning. Ventilator removal, if SBT is tolerated, minimum for 30 minutes. That is more than enough. No need of giving a TP trial for 1 day, 2 days, 3 days. Please don't strain out your patients, drain out your patients before weaning. Patient who fail an SBT should be ventilated for at least 24 hours and give a next SBT on 24 hours apart. It doesn't mean that in the morning we have failed the TP trial and evening again we start giving a TP trial. Use of sedation holidays religiously. Weaning protocol facilities are the process. Whenever you fail weaning, follow ABCDE approach for weaning failure. Assess your ABCDEs. Thank you. In life, you are either the pilot or the passenger. It is your choice. And if you are a good pilot, you may be able to land your plane even in a stormy weather. Thank you for your kind attention.